is a well-known distinguished speaker, Dr. Andres Ferreri. He is the head of the lymphoma group and unit and the contract professor at the oncology at the Università Vita Salute in Italy. He has been the founder of the International Extranodal Lymphoid Study Group, as well as the Italian Lymphoma Foundation. And he is a member of numerous international scientific societies. And he is also the faculty of the European School of Oncology. He published and authored numerous of scientific articles, especially on CNS lymphomas. The topic will be into the diffuse large B-cell lymphoma, CNS prophylaxis and management. Dr. Ferreri, the mic is yours.
Good afternoon, dear colleagues. Let me thanks to the organizers of this important meeting for inviting me. And my talk today regards the an important complication in the management of patients with large B-cell lymphoma, which is the central nervous system dissemination. And then I will discuss with you about the different strategies to prevent and to treat this dismal event. These are my disclosures. The central nervous system recurrence is a rare, fatal, early, but preventable event in aggressive lymphomas. As you can see, most of these events occur during the first year of follow-up and affect more or less 5% of patients with diffuse large B-cell lymphoma. Moreover, the impact on the prognosis of these patients is extremely negative because the mortality due to this complication is really high. The lymphomatous cells can reach the central nervous system by a hematological route, spreading directly from adjacent bones in the skull, in particular in the base of the skull, or from the bodies of the vertebrae, or by centripetal growth along neurovascular structures. This is more common in the lesions of the base of the skull or in the high area of the neck. The incidence of CNS recurrence in diffuse large B-cell lymphoma is more or less 5%. Most of these events occur during the first year of follow-up, with a median time between lymphoma diagnosis and CNS dissemination of 3-6 months, and with high mortality. The median survival after CNS relapse is between 3 and 5 months. An early detection and an effective CNS prophylaxis may reduce the related mortality. However, the scores and the predictors used to distinguish high-risk patients showed a low diagnosis sensitivity. This is mostly due to the inclusion of selection and interpretation biases in the retrospective studies. In particular, the exclusion of patients with CNS involvement of diagnosis reduced the proportion of patients with increased risk. The inclusion of various lymphomas entities in some studies where sometimes a central pathology review was not performed at all. The inclusion of patients treated with different regimens and managed with various prophylaxis, and the fact that sometimes prophylaxis was indicated according to homemade risk criteria. Finally, there are some extranodal lymphomas that are associated with an increased risk of CNS disseminations. And these subgroups of patients are scarcely represented in the review with the series. Then the results are that the impact of these high-risk patients on the overall conclusions of the study is unreliable. Some years ago, a group of colleagues designed a CNS, International Prognostic Index, using the variables of the International Prognostic Index plus the involvement of the kidneys and or adrenal glands. In this way, the patient with 4 or more of these unfavorable features were associated with an increased risk of CNS dissemination, close to 12% at 5 years. This was also confirmed by other retrospective studies, like the European study showing that a high CNS IPI risk group showed close to 50% risk at 5 years, and lower results, but also significant, were reported in the UK prospective series on a larger number of diffuse large B-cell lymphomas. As I said before, there are some forms of extranodal lymphomas with a higher risk of CNS disseminations, in particular those of the adjacent areas to the CNS, like epidural space or orbit, nasal cavity, and paranasal sinuses, and lesions from the skull and the spine. There are other extranodal lymphomas, like those arising in the adrenal glands, kidney, testes, and breast, in which this risk is not explained by anatomical reasons. In other forms, like those involving the Valdeyer ring, the ovary, and the bladder, these forms are associated with an increased CNS risk only when it is a part of a disseminated disease. And this is an important issue because these high-risk extranodal lymphomas are often limited stage disease at presentation with a favorable IPI scores. We can think, for example, on testicular lymphomas, which is most commonly as presented as a stage 1. 80% of this patient has a stage 1. And obviously, this group of patients is considered at low risk according to the CNS IPI. And this is a major limitation of this score. Importantly, the number of extranodal sites is associated with a higher risk, in particular when more than 2 extranodal sites are involved. There are some reports with disappointing results suggesting that double hit lymphoma and double expressor lymphoma and activated B-cell lymphomas are associated with an increased risk of central nervous system dissemination. However, there are very different results in some retrospective studies suggesting that in some series there is a significantly increased risk, whereas in the others there is not an increased risk regarding to these subtypes of lymphomas. In particular, in the double hit lymphomas, it's important to ask if this is biologically associated with increased risk of CNS dissemination, or if actually it is mostly due to the fact that the vast majority of these patients show high-risk features, in particular patients older than 60 years with advanced disease in more than 80% of cases, with increased risk, increased LDH serum levels, and with a very common involvement of extranodal organs. In other words, we don't know exactly if double hit lymphoma is associated with an increased risk of CNS disseminations by biological reasons or due to an association with other unfavorable features. Regarding the role of the cell of origin, there are some studies when the cell of origin was assessed by gene expression profiling, that showed that a different rate of CNS dissemination between activated B forms and germinal center forms. However, when used as excessive parameter, the significance was not achieved. Conversely, when we combine the CNS IPI with the cell of origin, we are able to distinguish 3 different subgroups with high, intermediate, and low risk, in which the 2-year CNS relapse rate is 15%. But the most important issue is that with this double strategy, we are able to limit the proportion of patients at high risk. It is only 8% of all the patients. In this way, with the use of this strategy, probably we will be able to reduce the use of superfluous CNS prophylaxis. However, as you know, the gene expression profiling is not worldwide used, and we will use this type of score only when gene expression profiling will be more consolidated in the routine practice. So when the patient at high risk were identified, we have to think about which type of prophylaxis we can use. There are several types of prophylaxis, in particular the Wolverine radiation, which got abandoned was used several years ago in highly aggressive lymphomas like lymphoblastic and Burkitt lymphomas, but then it was abandoned because it's associated with high risk of leukoencephalopathy, both in young and elderly patients. The use of intrathecal chemotherapy alone is associated with chemical meningitis, leukoencephalopathy also, and it is not associated with a significant reduction of this risk. The same thing is for intraventricular chemotherapy, delivered, for example, by the use of anomia reservoirs. And in this case, the septic complications are another major limitation. In the last 10 years, the use of intravenous high-dose chemotherapy, in particular high-dose methotrexate, was used as prophylaxis in several centers around the world. Also, this strategy is associated with risk of leukoencephalopathy, myelotoxicity, nephrotoxicity, and hepatotoxicity. Then the identification of the patient as the best candidates for this strategy is really important to avoid superfluous toxicity. So there are several studies in the literature. All these studies are retrospective. In some larger studies like this in Mexico, on more than 3,000 patients, the use of different strategies of prophylaxis were not associated with a reduction of the risk, which remained invariable close to 6%. In the rituximab era, there are some studies with using different strategies. There are some studies using intrathecal chemotherapy alone, and in this case, the results were not associated with a significant reduction of the risk in the CNS. Conversely, the other studies using high-dose methotrexate with or without high-dose cytarabine and with or without intrathecal chemotherapy were associated with a reduced risk of CNS dissemination. But most of these studies, with the exception of a single one, did not include a control group, that is another group of high-risk patients treated without prophylaxis. Then it's very hard to draw reliable conclusions on these studies. At our institution, we compared the results of 67 patients treated before 2007 without CNS prophylaxis, with 40 patients treated after 2007 with CNS prophylaxis. 33 patients received high-dose methotrexate, that is methotrexate at 3 grams meter square, or in 7 patients did receive only intrathecal chemotherapy due to limitations to receive methotrexate. And this strategy was associated with a significantly reduced risk of CNS relapse, which was 0% in the patient treated with methotrexate, conversely, in comparison to the 12% of the high-risk patient who did not receive any prophylaxis. Moreover, the CNS recurrence is associated with high mortality and obviously conditions the overall survival. Then the addition of high-dose methotrexate prophylaxis was associated with a significantly improvement in disease-free survival and in overall survival in the subgroup of patients who achieved a complete remission after R-CHOP. In fact, there are several retrospective and prospective studies suggesting that the use of high-dose methotrexate is associated with less CNS relapses, oscillating between 0% and 5%. And there are 2 interesting studies I wish to summarize from the Scandinavian group, where the methotrexate and cytarabine, delivered at high doses, were used in 2 different strategies: after R-CHOP in the first study, and during R-CHOP in the most recent study. In both of these studies, the risk of CNS relapse was reduced. But this, the comparison between these 2 studies opened the question about which is the best timing for the delivery of high-dose methotrexate. And there is an important international retrospective study coordinated by the UK colleagues that compared the 635 patients who receive high-dose methotrexate at the end of R-CHOP with 749 patients where R-CHOP was intercalated. The 2 populations were not exactly the same because there was variations in the significant differences in the risk of some high-risk areas and in the use of intrathecal prophylaxis and the number of courses of methotrexate and the cumulative dose of methotrexate, which was significantly higher when an intercalated treatment was used. And these are the results. As you can see, the 3-year CNS relapse rates were close to 6%, and there was not a significant difference between the 2 different strategies. Using a landmark analysis, that is, considering only the patient who achieved a complete remission at the end of R-CHOP, we can see that there are not differences in the CNS relapse rates, and there were not the difference in overall survival. Importantly, the use of high-dose methotrexate intercalated was associated with a delay in the R-CHOP, in particular, a delay of 7 days or more during R-CHOP. And this is an important factor because the delay of 7 days or more was significantly associated with a poorer overall survival. In other words, with the available evidence, the use of high-dose methotrexate should be delivered at the end of R-CHOP and non-intercalated with this. In some countries, like in France, in Paris, the colleagues are addressing the opportunity to treat these patients with the ambulatory delivering of methotrexate. This is an important issue, because all these patients for prophylaxis should be hospitalized, and this is an important issue in particular in the pandemic time. But it needs for a high selection of the patient, because only patient with an excellent performance status without any form of comorbidity can be managed with this strategy. In any way, with a suitable rhythms and careful patient selection, the tolerability was excellent. There were not G4 or 5 events, and there were a few G2 or 3 toxic complications. All this was perfect. Everybody was agreed that high-dose methotrexate should be used better at the end of R-CHOP. But some years ago, in the last 2 years in particular, there were some groups reporting retrospective studies suggesting that the addition of high-dose methotrexate is not associated with a reduction of the CNS risk. This is an example. The Alberta study in Canada. In this study, 906 patients were considered, and according to regional guidelines, those with high score, IPI CNS score, double hit lymphoma or testicular lymphoma, receive high-dose methotrexate. However, 1/3 of the patients at high risk actually, 2/3 of the patients at high risk did not receive high-dose methotrexate for different reasons. And these reasons were not explained and were not analyzed in the paper. Moreover, the number of the events was small, only 5% of the patient experienced this type of relapse. Then it is very difficult to draw any conclusion on this type of a study. We have to wait for a randomized trial. There is an ongoing randomized trial in Czech Republic comparing intrathecal chemotherapy with high-dose methotrexate in patients at high risk of CNS disease. But we have to wait for the final results to draw any reliable conclusions. In line with the Canadian experience, an international group of colleagues collected data from 2,300 high-risk patients and compared the use of high-dose methotrexate with no prophylaxis. In these patients, more of these patients receive R-CHOP, and 1,875 patients did not receive any form of prophylaxis. Only 392 patients received high-dose methotrexate. And the CNS relapse rate was close to 9% and 8% respectively after a median follow-up of 8 months. They're considered patients with diffuse large B-cell lymphoma with a CNS IPI of 4 or more, with high-grade B-cell lymphoma with microarrangements, and primary breast and testicular diffuse large B-cell lymphomas. However, these efforts were not able to demonstrate an advantage with the addition of high-dose methotrexate. The risk of CNS at 5 years was 8 and 9%, and it was not demonstrated also in the different analysis groups. When a landmark analysis was performed, considered only the patient who achieved the complete remission at the end of induction chemoimmunotherapy, there were not any difference in the risk of central nervous system lymphomas. Then this study should support the fact that prophylaxis with high-dose methotrexate did not produce any advantage. However, my interpretation of these results are completely different. When you check about the characteristic of the patients, 2/3 of the patients treated with high-dose methotrexate had 2 or 3 or more extranodal sites. Then we're at high risk of, at high and very high risk of central nervous system dissemination in comparison with the group who did not receive high-dose methotrexate. Moreover, 2/3 or the vast majority of the patients with treated with CNS prophylaxis had a renal, adrenal, and testicular involvement, which is well known associated with an increased risk of CNS. This was only 20% of the patients in the subgroup who did not receive CNS prophylaxis. In other words, we should expect a very higher risk of central nervous system dissemination in the subgroup of patients treated with high-dose methotrexate. Then when we observed that the CNS risk is similar between the two subgroups, probably my conclusion is that high-dose methotrexate worked very well, reducing the risk of CNS recurrence. In fact, as stated by Mark Twain, there are 3 kinds of lines: the lies, the damned lies, and the statistics. Regarding other forms of chemotherapy different with respect to R-CHOP, like ERDA-EPOC, there is this study suggesting that also in this case, the use of CNS prophylaxis did not improve the CNS recurrence rate, which was close to 6% in both subgroups. However, the CNS prophylaxis was at the discretion of the treating physician, and the vast majority or all the forms of CNS prophylaxis were intrathecal chemotherapy. Then, in other words, there was this comparison is biased by the use of an insufficient CNS prophylaxis. Interestingly, in the last 10 years or more, there were some randomized trials adding a new drug to R-CHOP in order to improve the disease control and cure rate in diffuse large B-cell lymphomas. And there are some efforts to establish if the addition of this drug was associated with the reduction of CNS relapse. In particular, in this study with the addition of lenalidomide, there were a small number of analyzed cases, only 136 patients, and importantly, there was a single case of CNS relapse observed in the high-risk subgroup of patients. Obviously, with this number of events, it's very hard to draw any conclusion on the role of lenalidomide to prevent this small complication. And the same thing we can do, we can say for other trials like those assessing for example, ibrutinib and lenalidomide in these patients. What happens when the CNS recurrence is already occurred? These patients showed a very bad prognosis, which is lower in the patient with a combined CNS and systemic relapse, in particular when there is an associated leptomeningeal dissemination, and the prognosis is poorer even in patients, most even in patients when the CNS dissemination occurs during the first line with respect to the others. The conventional dose chemotherapy plays only a palliative role, like intrathecal chemotherapy and whole brain radiation therapy. The only subgroup of patients cured with these complications were managed with high-dose chemotherapy supported by autologous stem cell transplantation. And the use of allogeneic transplant produced good results also in pediatric patients. However, this strategy is associated with higher treatment-related mortality and is not recommended to treat secondary CNS lymphoma when the patient is affected by diffuse large B-cell lymphoma. There are 3 phase 2 trials and a larger study on the routine practice using different high-dose methotrexate-based combinations with or without high-dose cytarabine. And in these studies, we observed that the overall survival at 2 years close to 63%. The OVUN trial, using a mix of RDAP and high-dose methotrexate, produced the poorest result with a 1 year overall survival close to 22%. In the Italian trial, including elderly patients and patients with a poorer performance status, the 2-year event-free survival was 73%, a very encouraging result, with an induction with high-dose methotrexate and high-dose cytarabine and rituximab plus intrathecal chemotherapy, followed by an intensification with high doses of cyclophosphamide, cytarabine, BP16, and then tiotepa-carmustine conditioned autologous transplant. The 2-year overall survival of this series was 83%. More recently, we reported the experience of the Marietta phase 2 trial when the patients were treated with 3 courses of matrix, followed by 3 courses of RICE. In this study, the rationale was they use dose-intensive treatment with active drugs with good CNS bioavailability. We allowed it to start the treatment with 1 or 2 courses of R-CHOP in some patients with extensive systemic disease, when in the case the life-threatening systemic disease. And we used the matrix, which produced excellent results in primary CNS lymphomas. And then RICE, which is a standard treatment for relapsed and refractory diffuse large B-cell lymphoma and is active in patients with relapsed and refractory primary central nervous system lymphomas. We allowed it to use whole brain radiation in the case of patients who did not achieve a response to chemotherapy before autologous transplant. And finally, we used the BCNU tiotepa conditioning regimen, which is safe and active in primary central nervous system lymphomas. And importantly, the predetermined efficacy threshold was achieved with these important results. The overall survival at 2 years was close to 45% in this series. But if we look at the transplanted patients, we observe that 80% of these patients is alive at 2 years. Very encouraging results for the futures. Moreover, the treatment was well tolerated. Obviously, matrix was associated with high rates of hematological toxicity because it's a very intensive treatment, but there was only 4 cases of definitive permanent interruption of the treatment, and only 4 patients did of toxicity, which is more or less 8% in related mortality. Importantly, the results were similar between patients with de novo diffuse large B-cell lymphoma and with transformed lymphoma, with a good tolerability also in both subgroups. According to subgroup analysis, we observed that the best results were achieved in patients treated at presentation and not at relapse. Also, in this case, patients with both brain and leptomeningeal involvement showed the poorer results. And importantly, 22 patients with brain and CSF disease at presentation had a 2-year progression-free survival close to 80%. Then, the central nervous system recurrence rate is a rare but fatal event with need for additional efforts to improve the results. In particular, to establish important collaborative studies and to investigate molecular markers predicting CNS tropism. To improve the safety and efficacy of CNS prophylaxis strategy, and in order to reduce the incidence of these dismal complications. And obviously, to improve the efficacy of treatments against both CNS and systemic disease. And now let me thank you for your kind attention.